Everybody's time. We're going to go ahead and get started. James Cena is popping in. As soon as I say something, somebody pops in. Let her go ahead and get joined before we start. Well, good morning to everyone. Like I said, we're going to go ahead and get started. Hope everyone saw the agenda. I will tell you, this year I told you were going to hear a little bit less of me, and unfortunately, you're going to get a little more of me than you bargained for today. I do want to say thank you to Janice Hillenbrand, Senior Budget Evaluation Analyst, who did some of the research you're going to see today. She's a little bit under the weather, so you're going to get to hear my interpretation of her research. But perhaps more importantly, we do have a guest with us here today. And I'm going to introduce Denise Price, who is the Forsyth County Behavioral Health Services Director. So as you remember, our work plan for this year looks at city and county collaborations and doing some research across jurisdictions in North Carolina about how cities and counties are working together. And we specifically talked about a couple of areas, and I'm going to use the term social services very broadly and call them kind of human resource services, those types of things. But Denise oversees some of these things for the county and has been so gracious as to come and talk to you about what the county does, particularly in her space. And we'll look at some of the overlap in areas where the city and county may be working in the same space, how we communicate and or collaborate, and then look at some additional places in those other jurisdictions where they may be doing the same thing with communications or collaboration. So we've got a couple of slides, and without any further ado, I'm just going to share my screen and turn this over to Denise.
Good morning, everyone. I really appreciate the opportunity to have this conversation today. It was kind of ironic when Janice called me. I was, well, I have a conflict right afterwards, and I'll be rushing to get somewhere else, so I'll have a hard stop time doing a webinar. And my co-presenters are Brent Motzinger, who's the battalion chief for our mobile integrated health program, and I'll tell you more about that in a minute, but also Kristen Ryan. So how ironic that we're talking about collaborations and I'm hopping off of this call to go do a presentation with City of Winston-Salem employee. So very nifty. So I wanted to start, and I do have some notes above my screen. So if you see me looking up to what looks like the sky, I'm looking up to another screen. My eyes are not rolling back in the back of my head. I'm good. Start with just letting you know kind of the structure of Forsyth County and Behavioral Health Services. Behavioral Health Services is a new department. The position was created and filled in June. Prior to coming to Forsyth County Behavioral Health Services, I was with Forsyth County Health Department. So I see some familiar faces. We may have interacted during the pandemic. And am just very gracious to be back in this space after that brief stint with public health, about 5 years there. And then prior to that, 25 years in the LME MCO, local management entity managed care organization space. So our Health and Human Services is a consolidated model, which means that we have a separate board from the Board of County Commissioners. It's an advisory board reporting up to the Board of County Commissioners. Our Health and Human Service Director is also our Deputy County Manager, Chantel Robinson. So a little bit different of a structure. Chantel was really managing behavioral health services for Forsyth County and during her role of Deputy County Manager. And as many of you are probably well aware, it's more than a full-time job. So the decision was to have a separate director. In behavioral health services for Forsyth County, there are several services or supports that fall under that umbrella. So I want to share with you a little bit about those as well. There may be things happening on the city side that complement. I don't think there's any duplicative services, but we'll leave that for your determination. We have a Stepping Up program. Stepping Up has two programs within it. SUPER, which is Stepping Up Process to End Recidivism, and the Mental Health Court. SUPER provides screening, transition planning, peer support, and case management to individuals who have mental health or substance use disorders. Most often, that is individuals who are in the detention center and planning for reentry into the community. We have peer support specialists who work with individuals to develop a wellness action plan. So they're really preparing for identifying what are my triggers, how do I respond to those, is proactive planning. And then once they are released, they have up to 2 years of support from the Stepping Up program. It can help individuals navigate housing, or getting a vehicle, or finding a job, or engaging in treatment. It really is whatever their needs are. It's very individual centric. We also do work with individuals not engaged in or not in the detention center, but primarily the referrals come from the criminal justice system. Mental Health Court is a program that is court supervised treatment for individuals who have been identified as having a mental illness. They have a pending charge and have agreed to participate in the program. It is a pre-plea court. It links eligible defendants to treatment and support services that help them to better manage their mental health. And again, we can help people for up to 2 years, so they get some really long-term supports. We also have a substance use health educator that historically did fall under our public health department. It has now been moved over to behavioral health services. This individual engages with a wide array of community stakeholders. They have a FROST program. It's the Forsyth Regional Opioid Substance Use Team. This team is made up of 80 different organizations currently. It's individuals providing services, it's individuals providing harm reduction, it's our hospital systems, it's our city partners, it's individuals with lived experience. And we come together to identify what are needs in our community, how do we collectively meet those needs, and how do we make sure that our synergies are aligned so that we're not off in silos doing the same work or trying to replicate work. It really builds some efficiencies. At our last meeting, we had presentations from our hospital systems, from Twin City Harm Reduction, which is the syringe service program in Forsyth County, and also from our mobile integrated health. And we looked at overdose deaths. When you look at overdose deaths, they get reported differently. So there's not a central place for reporting. Sometimes people that overdose use naloxone in reverse. And it never gets reported anywhere. But Twin City has a pretty good sense for how many reversals are happening. So they presented for us how many overdose deaths have been reported, or overdoses have been reported to them by individuals who said, we didn't report anywhere else. First responders report into a system called OD Maps. Now that's dependent on how people code a call. So if they code it as an overdose, it shows as an overdose. If they code it as unresponsive, it doesn't show. But if we look at those numbers with the numbers that Twin City has, and we also look at the number of people who present in Novant's emergency room, and we look at the number of people who present in Atrium's emergency room, we get a much better collective picture of what is happening in our community. So that's just an example of the kind of work that team does. We do have representatives from the city on that committee. PD is very active, always has been, and very supportive. We also have a pharmacy that falls under behavioral health services. And that pharmacy has been in existence for over 50 years. I think it's just kind of a hidden little secret that not a lot of people know about. And that's really because it has a limited formulary. So it's not a typical CVS or Walgreens. It is a retail pharmacy, but we don't stock all types of medications. Our primary customers come from public health. They are stocking for EMS. We have an employee wellness program. We do fill prescriptions on the formulary at no cost for employees. And about 70% of our work is dispensing of behavioral health medications, including some long-acting antipsychotic injectables, largely utilized for individuals with schizophrenia. And these injectables can help somebody to be stable for up to 6 months. So it's a wonderful combination. We work in partnership primarily with Daymark Recovery Services. And is an expensive medication. You think about an injectable that lasts for 6 months, you can imagine the cost of that. But we have a patient assistance program that works with manufacturers to get medications at no cost for individuals, which is hugely helpful. We dispense about $3 million worth of no-cost medications to the community each year. We also have individuals who don't have insurance, don't have Medicaid, but pay out of pocket for their medications, and we dispense at cost. So whatever we get it for from our wholesaler, plus a small dispensing fee, is what individuals pay for the medication. So it often is an affordable choice for individuals. Now, I mentioned that we don't dispense all types of medications, but we do work with our community partners to try to put that together for individuals. So Crisis Control might be an organization you're familiar with. They have the only free pharmacy in Forsyth County, but they don't carry a lot of behavioral health medications. They carry a lot of physical health medications. So we make a great partnership in trying to piece things together for folks. We also have a peer support specialist that is at the Central Library primarily. He does have some office hours at other branches. He primarily works with individuals experiencing homelessness, but will work with anyone who comes to a library branch or reaches out to be a connector to services. This is Jose Perez. So if you're down at the library sometimes, say hey to Jose. He works very closely with your bike patrol in the area. So we do have wonderful collaborations with city. When we're interacting with individuals, we don't think, oh, this is a city employee, oh, this is a county employee. We think this is a team. In case you want to know, our pharmacy is at 725 North Highland Avenue. Or if you know anyone who might benefit, have them to give us a call. We'd be happy to work with them to see if there's some way we can assist. And they are open from 7:30 in the morning till 5 in the afternoon, Monday through Friday, and they do not close for lunch. Also under behavioral health services is the management of some funds. So we have opioid settlement funds and we have behavioral health maintenance of effort funds, and those go out in the form of RFPs every year to support our community agencies. I know that the city also has opioid settlement dollars. I think the city has a smaller portion than the county. We do have an RFP open now that will be open through the 27th of this month to enlist applications from the community to help us to meet identified priority areas. We elected to go with option B, which allows us to use strategies under the settlement that they're so creatively named. So two options, option A and option B. Option A is a short list of strategies that an organization can meet or use the dollars to meet. And then option B is a bigger array. And if you choose option B, you can do everything behind door number A and everything behind door B as well. So just a larger array of strategies. Because we elected to go with the option B, we are required to have a opioid settlement stakeholder committee that builds a strategic plan. We are required to conduct a public session with municipal leaders, and we are required to reestablish what are our priority areas, to have a common mission. It's been a wonderful process. To get to the RFP, we had to go ahead and build out what our strategic plan was with this committee. About 60 individuals on the committee. Really, it kind of falls into that feel of Frost. It was a collaborative approach. It was a all hands on deck deciding what are our priority areas. It was identifying what exists, because how then do you identify gaps if we don't know what exists? And again, we did have city representation on that. And of course, our municipal leaders were invited to a session at the public library, and many came. So where are we and what are we doing? We have a couple of grants that we're working on currently. We are the grantee. So we have a grant with NACCHO, the National Association of County and City Health Officials, where we are expanding our harm reduction efforts through Twin City Harm Reduction Collective and engaging in a media campaign to inform people about naloxone. Naloxone, if you're not aware, is an opioid reversal medication. We have naloxone available to the public at no cost in our pharmacy and through a dispensing machine at the Forsyth County Sheriff's Office Detention Center. It looks just like you would go in and get a Frito or a pack of nabs. You type in what number you want, out pops naloxone, and it's again at no cost. So individuals can get what they need at either location, and we refill that frequently. So please let folks know that it is available to them. We also have a grant with the Appalachian Regional Commission to develop a recovery to work curriculum. We are in the planning stages for that, looking very much forward to having a curriculum that we can implement. We know that 70% of people with substance use disorders do work. And if we can help them through their recovery journey and be a responsible employer for individuals, it's a win-win situation. We get to retain valuable folks at our places of work, and individuals are able to feel the value of having a position. So we do have a couple of things in the way that I wanted to share with you. And although I had notes, I did forget to tell you about mobile integrated health. It doesn't fall under the auspices of behavioral health services, but I wanted to mention it because it is similar in concept to the BEAR program, although not duplicative in my opinion. Mobile integrated health is a team of advanced paramedics that respond to 911 calls or can be called directly to help mitigate behavioral health crisis. They do assessments and help individuals connect to additional services or resources. So I think in that regard, it's similar to BEAR. But where it differs is that BEAR, I believe, is staffed by social workers, where MIH is staffed by advanced paramedics. So Highland Avenue Center. You may or may not know about the Highland Avenue Center. It was built by Centerpoint Human Services when they were the local management entity managed care organization. It is now a building owned by Forsyth County. We have a vision for that to be a one-stop location for individuals with behavioral health needs. So currently in the building, we have open access outpatient. That means outpatient that individuals can walk into and receive services without an appointment. It's first come, first serve. It is operated by Daymark Recovery Services. We also have a behavioral health urgent care. The behavioral health urgent care is also operated by Daymark Recovery Services, and it's open 24/7, 365. So if someone's in a crisis on Thanksgiving Day and it's 3 a.m., they can walk in, no appointment necessary, do not have to have insurance, get an assessment, and stay up to 23 hours while that crisis is being mitigated and supports are being put in place. If someone goes to the behavioral health urgent care, think of it as a typical urgent care model, and their needs are greater than what can be achieved in that setting, then behavioral health urgent care helps to connect people to the individual services that they need. That might be a transport to an emergency room. That might be to an inpatient center. That might be to a facility-based crisis center or a residential program. They do primarily serve adults, but they will also see children as spaces available. There also in that building is a primary care. It is a joint venture operation between Novant and Atrium. And the vision of them being there is really to think about holistic care for individuals. We know that folks with severe and persistent mental illness die about 25 years younger than their peers without diagnosis. And oftentimes that's a preventable or a treatable disease that they have. So having the primary care there helps us to look after a whole person. You do not have to be a patient of the center to go to the primary care. We do have employees, for instance, who choose that as their primary provider. They're on a sliding scale fee. So minimum is, I think, a $40 fee, but they also have x-ray on site. They can do small surgical procedures. So you get just a wealth of available resources. Partners Health Management, the local management entity, MCO, also has space in the building. But wait, there's more. So we're working right now on upfitting that building. So I said the vision is a one-stop shop. So it's sort of a one-stop shop now, depending on what your needs are. There's an open shell second floor that's being built out, and there's work being done down on the first floor. So projected December of this year, we'll have a 16-bed adult facility-based crisis center on the first floor. That's a space that's much between a behavioral health urgent care and an inpatient stay. So individuals who might need more than 23 hours of care, but really don't need inpatient, can go and stay 5, 7, 9 days to detox, to stabilize, as plans are being built to be able to serve the individual in the community. Stepping Up that I mentioned earlier, and our health educator with Frost will be moving over to that building, as will I. There is space for additional build out, and our pharmacy on a last leg of transition, probably closer to the end of 2024, will be moving over to that space. So our goal, make it easy for folks. The behavioral health urgent care, the 16-bed facility-based crisis center can take IBCs and voluntary committed individuals, so it can be a drop-off space for your first responders. So I think there's going to be huge opportunities for continued collaboration in that space. That sums up behavioral health services. Be happy to take any questions.
Thank you for the presentation, Ms. Price. I have a question. Are there any programs set up before detention, like for behavioral health? Are there any programs that will help individuals before they get into the criminal system?
100%, yes. So I mentioned WRAP. WRAP is Wellness Recovery Action Planning. That's a program that is offered by Stepping Up. The sheriff has an apartment at Piedmont Circle, and we have begun to do WRAP sessions there. WRAP is one of those things that it benefits anyone. Like, you don't have to be in crisis. You don't have to have a behavioral health diagnosis. It really just helps you to plan and to think through, what am I going to do when something happens that throws me for a loop? And I think all of us get thrown for a loop occasionally. So we're doing WRAP there. We're also doing WRAP at some other community locations. So that is something that's more on the preventative side.
Okay.
We are also renovating across from Highland Avenue Center, the Annex 1 Auditorium. And there's going to be a park in the back of that. So the vision is to really begin to bring in some healing kind of programs where arts and health can intersect. So I think we'll be moving more toward that. Medication compliance, of course, is another way to mitigate crisis.
Right.
And for individuals to be able to remain stable, but oftentimes that's a cost barrier or an access barrier. So our pharmacy certainly promotes prevention. And Jose, our peer support specialist at the library, is not only somebody for folks to reach out to when they have crisis, but he's just a continuum of support for folks. His phone rings often. He creates relationships and is available and shows up. And oftentimes that's very helpful. In terms of community providers, I think of folks like Green Tree Peer Support. Green Tree is a facility operated by Laurie Coker, and it's where folks can go to hang out, in a safe space, to get assistance. And when I look at her monthly reports and what people are coming in identifying as a crisis are really things people just need help navigating.
Right.
I lost my cell phone. That's my connection to everything, and I don't know where to get one. She'll help them get a phone. I'm unhoused and I don't have a place to live, and somebody stole my tent. She'll help them get a tent. I don't have food. She'll help them get food. So it's things that typically she can very quickly, and her team can very quickly mitigate.
Okay, and one other question, follow up for the free services. Have we thought about connecting with the county school systems to help teens, because, you know, even though you have services in strategic locations throughout the county and the city, all students who are in need of behavioral health are not able to get to those locations. So is there any future plans of connecting with the school system?
It's a fantastic question. Yes, in fact, that's where some of those behavioral health MOE dollars go. We currently, again, it's every year. So the last few years, we have funded the School Health Alliance. The School Health Alliance is in the schools. They don't only serve the children, but they serve the families. So you think about that school being in the neighborhood or closer, and more accessible. They do behavioral health screenings, they provide behavioral health services, and they do physical health services. So again, kind of wrapping around that whole person. We are not segments, we are whole. And we also this year are funding CrossNor. CrossNor is doing training for teachers on providing trauma-informed support to the students, and also doing therapy for kids at several schools.
Thank you.
Denise, I think, and Scott confirmed for me, part of our charge this year, our main charge is looking for opportunities for Forsyth County and the city to partner. Could you talk a little bit more? I know you mentioned briefly that there's some touch points with that position at the library. What other opportunities exist or are being implemented?
So I think opportunities that exist, we're all trying to figure out opioid settlement dollars, right? So making sure that we're not funding the same things if the same things don't need to be funded. So obviously with that caveat, settlement is growing. So when I first came into my position, we were projected to receive Forsyth County $19 million over the course of 18 years. That then currently is at 24 million. But new settlements are coming down that could double that amount. So I think the more money we have, probably the more at risk we are of going into silos, just making sure that we're talking, right? And that we are planning collectively for the community. I think also with BEAR getting up and running, there will be opportunities to talk about how does BEAR and MIH intersect? Where are those crosses? Do we all respond? Does BEAR respond to some? Does MIH respond to some? Is it dependent on the call? How do we train our call centers to make sure that we're dispatching the most appropriate resources, knowing that sometimes you get on scene and it looks different. So there are opportunities there. What I will say is that Kristen is fantastic. I think she was on day 2 when she was sitting in my office saying, tell me about what you do. How do you do it? So she is game on making sure that we're working together and doing things in the best way we can for our citizens.
I would just note there, I don't know that the CBAC has heard Kristen's name. She is the BEAR team director. Just did a little presentation in front of the city council committee structure this week. And so she has been very busy here in the first few weeks that she has been employed. We were unable to get her for this meeting, but that is the BEAR team director, and she is working very fervently to get the rest of those positions filled, to get that program stood up here as quickly as possible so that they begin responding to some of those calls. The hope would be here in the coming months that they are stood up and beginning to actually make response in the community.
Also, just keeping one another aware of what we're doing and what programs we have. I think we're all just dot connectors, right? We connect people to what they need, but we can't do that very well if we don't know what's available. So making sure that we have our open communication and are familiar with what is available. We work closely with so many city departments to help to meet individuals' needs, housing, for instance. With staff turnover, that can become a bit of a challenge, like we're constantly having to re-educate about what's out there, what's available, who are your contacts. But that would be a big need from my perspective.
And Sheila, my general response to that would be Denise is a little closer to boots on the ground with some of these things than the budget office is. So we've done some research on what other communities are doing, but when it comes to what's actually happening in those recommendations, they come better from the practitioners. But we're going to show you some additional areas and talk about a few other things where we may look at that continuum. And I think the way I think about it and the way Janice and I have thought about this research is there's kind of three levels here. One is exactly what Denise was talking about, which is communications, just making each other aware of what you're doing and where you're operating in the space. The middle of that continuum is collaboration, where you're actually working together, even if you're not jointly funding the same program, you're operating in the same space, you are working together. MIH and Bear are in the same space, changing response protocols so that they don't both show up if they don't need to. And then the far end of that continuum is a joint service provision, where you are jointly funding the outcome and the program and operating off the exact same series of protocols and procedures and policies. And so somewhere on that continuum is everywhere that we operate in those spaces. But yet definitely there are areas where we might be moving from just communicating and knowing what we're doing more into how do we actually collaborate or even get to a joint service provision in some of these areas where we're joint funding the exact same outcome with the same response.
I wonder, just a question, thinking out loud based on what Denise said, is there a fourth continuum which is more of the vertical? Because I think what Denise said is in addressing the mental health concerns, there might also be a need to tap into like housing and other areas. So maybe there's another continuum. I don't know.
Denise, if you want to take that one, you can.
It was breaking up for me. Could you repeat it?
Sorry about that. So my question was, Scott mentioned three verticals that they're talking about: the communication, collaboration, and joint services. And then based on what you said a minute ago, I was wondering if there's another vertical to contemplate where you see that it's not the mental health concern that we're dealing with, it's some of the holistic things that might be needed, like housing, I think was a specific comment you made.
Absolutely, absolutely. There's certain basic needs that have to be met before we can even begin to address behavioral health needs, right? Housing, food, all that hierarchy, Maslow's hierarchy of need. So definitely. And do we have housing issues? Absolutely. Do we especially have housing issues for people in recovery who might have felonies? I mean, there's so many complicating factors. So absolutely, I think there's an opportunity to work together to think about what are approaches that can be utilized. And we've got folks in our Stepping Up program, for instance, who boots on the ground are dealing with issues every day and can tell you what the barriers are. So are we a part of a focus group, perhaps? Maybe. We do participate in the continuum of care, but do we need to have more conversation around certain barriers that our community is experiencing?
Another question you just made me think about with the jail services that you do and addressing getting back to work and reducing recidivism. I think the Forsyth or the jail and prison ministry, do you coordinate with them also? I know that you mentioned another group that you coordinate with.
So we work real closely with the jail health provider, and we work closely with the detention center office, but we don't work closely with their chaplaincy. So perhaps that's an opportunity.
Okay, thank you.
Our detention center, you may know, has a behavioral health unit for the males. That's been hugely successful. So when I say we work closely with the jail health provider, it's usually in that space.
Denise, I just have one kind of big picture question. So if this is too big, feel free to just shut it down and move along. But you've been in this role for a short time, but I'm just wondering, kind of as you stepped in and as we get to now and look to the future, one, what's changing? And what are the public needs that are changing? And two, what do you think, if you could pick one or two or something that would really move the dial from your end, not just injection of dollars, but some practical things, as we kind of look at it from a budgetary perspective, what would that be?
So great question. And I'll tell you what I think is working well and where I think we have needs, if that's okay. So I started in this field when I was 18 years old at Guilford County, just long enough to get a little bit of experience, and it stuck, right? So I've been doing this a long, long time. And for the first time, I feel a real different synergy than I've ever felt before. The little thing called COVID, I think, really pulled us together, right? Like we developed different relationships than we've ever had. We had to flex our muscles together in ways that we never had. And that has taught us what we're capable of doing. I see transparency. I see the competition breaking down between providers, that folks really see a more continuum and collaborative relationship, as opposed to, we can't talk to you because you might take our business. COVID too created some issues in our systems, both from a people and a workforce perspective. We don't have enough behavioral health providers. We don't have enough direct care support providers. We see it everywhere. We have vacancies, we have turnover. So stabilizing our workforce is a huge need. In addition, once we do that, perhaps then we can begin to build out our capacity. Until then, we've got to figure out how to build our capacity with what we have, so that we can meet the growing needs. We had a lot of people whose lives were lost. That has certainly impacted it. That has affected families. We have an economy where things cost more. It's harder for individuals who might not have struggled before to be able to feed their families. So there's a lot of just tangential kind of issues that we're seeing more prevalently with the population that we work with. So the good is, I think we're better poised to begin to address these things, right? One, we have money where we've never had money before, in droves that we've never had money before. So we have the dollars to help to find solutions and support solutions. But the workforce issues are big.
And then just one getting even more micro now. You mentioned the availability of naloxone to the public and kind of the free program. My next question was, has there been any talk about maybe training for the public? I know there's been some movement in schools to have that conversation, to train, if not, public servants with naloxone, but just availability to the general public. Absolutely.
So that is the goal of our health educator, is to make sure that everyone's got naloxone that wants or can carry. And there is an education requirement for that. I'm talking to a lady this week, and she has a family member who is in chaotic use. And I encouraged her to get naloxone. And she said, "Oh, I have some. The police officer who came out the last time brought me some." So great job. But we talk about, and we're doing campaigns around naloxone and why it's important. We talk about preparing for a fire. So to prepare for a fire, we have a fire plan. We practice our fire drill. We have a smoke alarm to alert us if there is a fire. And then we have a fire extinguisher to put out the fire. Naloxone for us is the fire extinguisher. So we want folks to be educated, to, if they see the need to carry, and then to be able to use. As an example, coming out of the dispensing machine, we had a citizen who was walking downtown, found someone that was unconscious, thought they may have overdosed, called 911, which they should have done, and ran over to the detention center, got naloxone out of the machine, came back. By the time they got there, PD was there. They actually didn't have a naloxone on them, but he handed them the naloxone and they reversed that overdose. So using stories like that to show to the public that you can make a difference, and having people who have been reversed, who say it wasn't the first time I was reversed. Maybe it wasn't even the 10th time I was reversed. Maybe it was the 15th time I was reversed. I was ready to go into recovery, and now I'm on my journey. Thanks for letting me get on my soapbox, Tony.
Any other questions for Denise at this point before we pivot a little bit and look at some examples of other things? If not, Denise, I will say thank you. You are more than welcome to hang out as long as you want to here, but knowing that you have another meeting, if you need to slide out and in preparation for that, feel free to do so.
Thanks so much. Thanks again for the opportunity for the conversation. Y'all have a great day.
So
Thanks,
before I share my screen again and go through some of the examples, I do want to hit on two things. So obviously Denise talked about a lot of areas where the city and county are already operating in the same space. So we talked about reentry services, which you'll see a little bit more about from the city. We talked about the opioid settlement fund, so looking at substance abuse, both response and treatment protocols, mental health response with our BEAR team and their MIH program. And then she also started talking about certain prevention strategies, and the city works in that space with some. And I think you'll actually hear, we'll probably talk more about prevention and intervention strategies on the law enforcement side of things and with youth violence intervention programming next month. But there are a lot of places, particularly, she didn't mention the cure violence model, but there are some areas in that space where the city and county both have funding from the state and will be directly collaborating on programs. So there is a lot of overlap there. The context point I want to put to this, and we didn't discuss it at the beginning, is kind of the statutory role of the county versus the city. What cities do and what counties do in these spaces are often defined by what we are required to do or not do. And in this area, counties are required to provide public health services. They are the entity for that. Cities are, by law, technically not charged to do much and do basically whatever they want to provide to their residents. Cities are only technically required to do like building inspection services and have a city clerk. We choose to provide fire, sanitation, police services, recreation and parks, all of those other areas. And the reason I bring that up is historically what you have seen is the county is the sole provider of many of those types of services, along with the nonprofit community that they are working in. And more you are seeing cities in North Carolina kind of get into this space. And I think there's two reasons for that. When you hear people talk about it, one is just the proliferation of need, particularly in Winston-Salem, Forsyth County, as you grow. The larger your city grows, the more you see these types of things, and the more the city council is engaged in these types of things. And from a political sphere, I will tell you, city council members meet with and have these discussions with other elected officials in other states and other cities throughout the country. And one of the things that's always interesting to us is many of those cities that they talk to, they don't have the same structure that we have. Many of those cities are what we would refer to as independent cities, and they provide basically the city and county functions. And so what you see are a lot of the research and a lot of the anecdotes are from places where the city is providing public health and mental health services because they are actually the entity to do it. And so our council members will go and say, oh, look what Kansas City is doing, or look what Roanoke, Virginia is doing. And sometimes we have to remind our council members, you may, per state law, absolutely engage in this. It's not a core function of city in North Carolina, and particularly that we've historically provided. But some of the times when you hear about what another city is doing, it's because they are actually charged by law with doing that. And so that's part of that, just that kind of context and historical political space of what does a city do in North Carolina. Realistically, when it comes to social services, those types of, and I'm using that very broadly for public health services and everything else, cities generally are not involved in that because we were not required to by statute. You do see cities becoming more involved as residents say these are services that we want and that we see a need for, and cities see a gap or a deficit in county funding or programming, and in some ways are meeting the needs. Look at something like the Bear Team, and although that's design operating in this space, that almost got arrived to as a result of issues with our response in police. There are so many of these calls that police officers are going to, and they're not the right person to be there. So there's this just very interesting conflux of, how are we arriving in the public health and social services space? And it's from what elected officials may be seeing in other places. It's from direct needs that we have from departments, and it's hearing stories from residents out in the community of services they feel that they need. So just wanted to put that context note out as we talk about a few things here. This is an area where the county has been for a very long time, and where we're trying to figure out what is that communication, collaboration, or service provision, and where should the city be in those spaces. I will say Janice did a substantial amount of research in different cities and counties, and we're going to look specifically at Raleigh and Wake and Durham. But what I would tell you just as a high note is there's communication in some of these areas, but you don't see a lot of really direct collaboration or really getting to that joint service provision. We're going to show you a couple of areas where cities and counties may be doing that. But just like we saw on the affordable housing side, I think there's a lot of people talking about wanting to work together, and it's very difficult to make that leap towards actually providing the service together, defining the same outcome, and making sure that everybody's on the same page. So we are also, from a budget perspective, going to show you something that's just mildly interesting, which is a lot of cities that operate in this space do it not just collaboration with the county, but realistically do it through funding nonprofits. And different entities have different levels of funding. So we're going to show you some of what Forsyth County funds through community agencies and what we fund through community agencies and the overlap. And then we're going to show you in those two examples in Durham and Wake County, where the cities and counties are or are not doing the same. In some of those cases, the elected boards are making very clear decisions to support specific types of services through community agencies. In other areas, departments may have some operating contracts, and those, quite frankly, are a lot harder to find when a department in, say, the city of Raleigh or Wake County is specifically managing a contract for service that doesn't show up anywhere in public records or budget documents that's easy to find. So this is going to be an informal discussion. What I'm getting at, stop and ask questions if you have them, but at a high level, we're going to show you some tables here. I wouldn't get caught in the individual types or organizations that are being funded, but think more about the types of services that are being provided. So let me share this. And like I said, feel free to cut me off at any point, but Janice did a lot of research and pulling things together here in terms of what's funded in other areas. Let's see here. Is everyone seeing that presentation? Okay, so I will skip to, going to talk really quickly about, again, I'm going to use the term community agency, but every organization calls it something a little different. These are kind of funding 501c3s in different areas. We're talking about kind of public health and social services, but we're also going to show you some of the community and economic development and arts areas here in Winston-Salem and Forsyth County, just for fun, because it was all part of the same documentation. But if you were to go into the Forsyth County budget document, you would see organizations like these. So first off, TransAid, and we'll show you where the overlap is. TransAid is obviously a service that the city provides and the county shares in outside city limits. But many of you might be familiar with what ESR does, Neighbors for Better Neighborhoods, the Harry Veterans Outreach Program, Boston Thurman Community Network, and some of what they're doing with respect to housing and pre-K services. So there are several agencies that the county is funding at different levels for all types of things here in kind of that social services space. And again, I don't want to get hung up in exactly how much each one is doing, again, I told you we'd show you the arts and community or cultural agencies. We'll come back and talk about this one too, but this is another space where the city and county are kind of funding the same thing and we're in the same area. You'll see things like Arts Council, Old Salem, River Run, National Black Theater Festival. Those will all show up again on the city's list. And then a couple of other areas where the county is also involved, where the city is not currently, but there are things, I mean, for instance, they're funding the Humane Society. They used to have a very large contract with the Humane Society. But some of these are areas where even if the city's not funding it, that doesn't mean that those organizations are not reaching out to city council or submitting applications. They're just not areas potentially that we operate in currently. So again, I'm gonna kind of parse through on the city side. We tried to match up some of the same areas, and this is by no means an exhaustive list. We're just trying to provide some context. But you'll see things like ESR. Obviously, you saw that on the county list. You see it on the city's list. We're doing some things more in the line of, well, you see drug treatment court, which Denise was kind of hinting at earlier. Elder services, working with youth in the community. So some of these are areas, again, where the county and city are working together. We do have CDBG funding where we fund a lot of stuff, particularly in housing and homelessness, but for low to moderate income. And so you see, again, there's Harry's, the county is funding veteran services. The city is also providing funding for veteran services. That's one of those areas where more generally, do the city and county, are we communicating about what we're providing to these organizations and these services? Perhaps. Are we collaborating and jointly funding outcomes? Probably not. So, some of this ESR has multiple programs that are actually funded in different areas. But one of the recommendations, and Sheila, you were kind of talking about this, where is the city communicating versus where can we get more intentional? And so you may, as a group, look at some of these areas and just say, we would recommend that city and county staff, if you're not communicating, communicate, but definitely be more intentional. We see that you're funding elder services or veteran services or mental health services. You really need to have some kind of joint group of city and county folks that are meeting together on a regular basis, talking about what you're doing. For what Denise was talking about, not duplicating a service unintentionally. Not that a nonprofit would specifically ask us to do that, but I'm sure if we were both funding the same thing, they would love to have the money, even if it's helping support something else.
I have a comment. A question and a comment.
Yep.
So am I understanding correctly that we are collaborating more with the county? And if that is true, I believe that one way to inform the public is we continue to use technology where we could do a video on the joint services or a roadmap to the joint services for the citizens to be aware of. We could maybe run a commercial on Channel 14 about those joint services and that roadmap once this group decides how often the group should meet, setting up a schedule, informing the public that this particular meeting is going to happen and maybe report it on TV 14. Is that possible?
So TV 13, yeah.
13, I'm sorry.
Yeah. And we direct everybody to the city's YouTube channel these days. Everything that TV 13 records is saved out there. He said at the beginning of that question is the city collaborating more with the county? And I think what you heard Denise say is yes, we are beginning to operate intentionally more in the same spaces. And we do need to have those conversations around and I think they're happening at a staff level. Obviously, Denise was leaving literally to talk to city staff about how we're providing a service and they're providing a service. But if you want to get to that, what is the real outcome? Do we have the same outcome and are we working together on the same service? Yeah, I think there's more room for collaboration in a lot of space, whether it's housing related, like we've already talked about, mental health services, other areas, again, elderly and youth violence program. There's a lot of areas where we're really starting to collaborate more. And in terms of if there are physical structures in place, then absolutely we could record those types of things and make things public so that anyone would have access to that. I think right now, what you probably have is a lot of staff discussions that are taking place in some of these areas, and there's not a coordinated task force that's looking at mental health response that has city and county appointed folks who are making decisions of any kind. What you have more of in those spaces is department directors and practitioners talking with each other about where we're operating and how we're doing it to try to avoid duplication or to support each other where we can and where it makes sense to be more efficient in just providing the service. And again, I'm going to kind of just run through these. The city, as CBAC is aware, provides annual funding to a lot of what we would call arts and science organizations, but we'll show the overlap here. The idea in looking at these slides is the county has quite a few areas where they are funding nonprofits. Even if they're not providing the direct service, they're still funding a nonprofit who's doing in that service, and so is the city in that area. I would show you, and I think we got, these don't include ARPA funding. This is just looking at kind of annual funding where we're in the same area. I told you ESR is one of those areas. The city and the county are both funding ESR. We're both funding Harry's. We are both funding Boston Thurman, although I've noted there the city's current funding support for the Boston Thurman initiative was $300,000 and ARPA provided, but they had a more than $3 million request. And we do have some housing money that's sitting aside that they may potentially use. But again, some of these other, Liza's Helping Hands, My Brother's Second Chance, I left guide on here. So that's Bill McLean's group that operates out of the Winston Lake Y, what will be the Reach Center. The county is providing funding to them, but the city has historically, we provided about $53,000 worth of funding and one-time support to Guide last year. That's operating again in that kind of youth intervention and mentoring space. So there are a lot of areas, even outside of our structured programs, where we're joint funding. And again, just for kind of context here on the arts and culture side, we're both funding the Arts Council, Old Salem, River Run, National Black Theater Festival, and Callidium. We do have some asterisks on there. The Arts Council and Old Salem also both got substantial amounts of ARPA funding from the city and county as well. So this isn't social services, this is kind of arts and science culture. But again, a lot of overlap in terms of who's providing funding for at least general support, if not specific programming in these areas.
Hey, Scott, I've got two questions for you.
Sure.
One, looking at these, it looks like, and so is it fair to say that the city funds fewer agencies, but with more money per agency? That's what it looks like right here. Is that a fair assessment?
I don't know that I would say that. I think in some of these examples that may be what you're seeing, but we do have a lot of organizations, particularly in our SOAR area, where we're providing $5,000 and $10,000 grants to organizations to help with reentry services. So there are some areas where we may be providing more, but we do have a lot of
just on these two tables, it looks like it's more directed funding in terms of fewer agencies but more money. Second question, it looks like the county is giving money to a city department with TransAid. Is that to expand the services out to the county?
Yeah.
Okay.
So that's a kind of joint collaboration. It's the city-run service and the county is providing funding into it. So, yeah, it was on the county's list of community partnerships, and so we included it that way.
Hey, Scott, you mentioned it earlier. Is there information about the outcomes that the county is expecting and the city is expecting relative to the funding?
So that is a tricky question. And the answer is, on the city side, for each one of these organizations, they go through an application process. For the ones that are federally funded through federal pass-through money from HUD, the outcomes are much more defined for exactly what they have to do and what they're reporting on. For the local funding, We allow them to kind of tell us the space that they want to operate in. They give us their performance metrics and they're required to report on them. We show those performance metrics to city council, but I don't know for those that there's we've had this discussion with city council. If a nonprofit were to receive money and miss their performance metrics, a lot of times what they would relay to us is it's simply because we weren't funded high enough to hit the goals that we needed to. So there's a lot of space where the city and county could work together on what are those specific goals and outcomes that we're looking for. The other thing I would tell you, some of these, we're generally funding the administration of the program, even if they're reporting what they're doing. I'll give you a great example as we look at this. So you see National Black Theater Festival up there. We are supporting the North Carolina Black Repertory Company and specifically the National Black Theater Festival that happens every other year. But we didn't decrease funding when COVID hit because they had fewer people coming to the city or they had fewer offerings or shows. So we require performance data as part of the contract, but in some of these cases, we are generally supporting the program and the outcome is not inherently tied to the amount of money that they're getting. Is that?
So, Scott, oh,
Go ahead, Fred.
oh, so if I would sort of interpret and rephrase that, so you're saying that oftentimes you're essentially funding sort of the infrastructure, and then they're expected to go out and raise additional money to actually provide the services. Would that be a fair way to say that, or?
Yes, we are generally only part of the funding of most organizations. There are some smaller organizations where we may provide a substantial component of their operating budget. I would say generally the rule is the city doesn't want to be more than a 10% funder in an organization. I will tell you there are very small organizations whose entire annual budgets are $50,000 or $60,000, and it's very difficult to give them any amount of money and not exceed the 10% threshold. But there are organizations, yes, where we're supporting the administration and infrastructure, and they are providing the service partially with that money or by doing additional fundraising or with volunteer work. Some of them have a lot of volunteerism that they're using for actual service delivery.
That sounds completely reasonable to me.
Okay. So again, the intent of showing this was to show there are a lot of spaces where we're funding either the same organization or just more generally in the same area. And one of those recommendations may be for the city and county to think a little more collaboratively about the spaces that we're in. And Sheila, what are the outcomes, not just the organizations that you want to fund, but are there specific outcomes that we want to fund as well? Going to jump in here. And again, we talked about some of these, so I'm not going to belabor everything. SOAR, you've heard us talk about. There are really two components of SOAR. So you see up there, successful outcomes after release, really reentry programming. One side is what you see here, which is where we support community agencies that are doing reentry programming. On the other side of that, the city actually has an internal work preparation program and job training or job skills program that we provide. So this is just showing you where we fund community agencies in that space, but we also do have a budget where we bring in individuals, we let them train through a program and even work in city departments to get skills that are necessary to find a job. So we're operating in that space. You heard Denise talk about several programs stepping up that are reentry programs. So another area, city and county are complementing each other and are working in the same space. And even in a conversation with Denise, I would tell you there are folks in some of their programs who they recommend over to our programs once they get out. So there is some level of communication and collaboration there. Again, we've talked about the BEAR team, a total of 7 positions, 1 kind of supervisory director level position, 6 clinicians who will be responding to low risk mental health and substance abuse issues that do not present as having any sort of violent response issue. Yeah, Fred.
Are these dispatched through 911?
Yes, absolutely. So those calls come into the 911 center. And the idea is if we can appropriately dispatch that on the front end, you would get a bear team unit instead of a law enforcement officer. There are probably some places where they're going to send both, where it seems like bear should go, but you may also need a law enforcement officer. And I think what we'll also find is we're going to send a 911 or send a law enforcement officer on scene. They're going to get there and realize it's probably not them that needs to be there. And they may call the bear team to get to the scene and allow them to leave. So there's going to be some different ways, but yeah, it should happen primarily at the dispatch center. So again, Denise talked about mobile integrated health, where they're using basically trained paramedics to do some of the same type of work. And so they're doing evaluations of sorts. I don't know the details. And again, I don't think that they're going to be providing quite the same level of support as a clinician would on site, but those are areas where we are directly overlapping. And you heard Denise say, we really need to be careful and have some conversations about supporting each other in those spaces where we can. We talked about the county funds, the drive program the city funds the drive program in Forsyth County, which is it's a driver's license restoration program for people who have lost their license for very small offenses and for not having paid traffic court violations and things of that nature. The DA's office is actually involved in this. So district attorney staff goes through and works that case on whether or not they can throw out the charge. And if they can, I think they even go through whether or not they can expunge records for certain purposes. But the city recently put an additional $300,000 into this program for, I believe, another 24 or 36 months worth of programming on our side. So again, that's one of those areas where we're kind of getting into something that wasn't historically a core service for the city.
Scott, real quick, this touches on kind of the last two slides, actually. It's a thematic link, I guess, but there was a little bit of conversation earlier about the building out of the Highland Ave Center. And one of the things that I kind of jotted down was transportation related. I know probably that emergency EMS probably does drop off there from emergency room services if need be, but I'm wondering if there's any sort of initiative or energy behind finding a way to do direct transport out there, especially as the kind of walk-in medical or mental health services grow.
Tony, that is one that I will write down. It is a great question, and I don't want to step outside my budget lane and start answering things incorrectly. I do know that the BEAR program, we are purchasing vehicles for them to be able to do transport.
Okay.
And so at least on the city side, there's an opportunity for us to provide those transport services where needed. But that is all. Your question is also a much larger question about overall transportation needs to those services at different entry points.
The question was born out of that kind of emergency response, but also thinking in the bigger picture about kind of making sure that is the ease of entry continues to grow.
Yeah. Very good. Sheila, did you have a question as well?
I did. On the visual, it looks like arrows, but as I read the bullets, they don't appear to be a cycle. And I just wanted to make sure that you could clarify that for me. Are they related or independent items?
So I will tell you, we have stolen the visual, and again, it's not a city-run program. So when you look at that, they are not, I think, consecutively in order in terms of the cycle. So you got, can't afford your fines and fees would lead to an indefinite license suspension because you didn't pay them. There are a lot of folks who are driving without their license because they simply have to get to work. They don't have a choice. But it may be that the entry is down there at the ticketed level. You can't afford it. You appear in court. Again, I know we stole this from the program itself. I think some of those go in nature, and it may be that the entry point is down there. The way this thing works in general, if you get a ticket and you fail to appear, you don't have the financial resources to pay it, or quite frankly, sometimes people just ignore it. The idea is you've gotten the citation, you have failed to remedy that, and as a result of failing to remedy that, your license has been indefinitely suspended, and the DA's office is going back, looking at those and basically overturning those and throwing them out if they can. So sorry for the visual. And again, I'm not a representative of the DA's office, and I don't want to represent that full cycle, but I know we had kind of stolen this visual from them. So
Thank you. That was really helpful for me.
gotcha. So getting into a couple other examples, we'll stray away from Winston-Salem and Forsyth County and talk about Durham and Wake County with Durham City and Raleigh, obviously. There are lots of differences here. When Janice was talking with other city and county staff, both in budget and in some of these departments. And so I think this is an area we're going to show some information. It's probably ripe for a lot of questions and for us to do some follow-up if you'd like to. But starting with the city of Durham, they have a HEART program, which is somewhat similar to BEAR, but I think even moving further than that, where they are actually operating with the county. So if you look at that second bullet point, you'll see responding units have a licensed clinician, peer support specialist, and EMT provided by the county. So this is that collaboration and then moving to joint service provision. So they've got a clinician and that EMT that Denise was talking about, we're literally working together in the same vehicle on the same call. And so this is one of those areas between Durham City and Durham County where they're beyond communication. They have collaborated and they are really moving into joint service provision. So just wanted to show city and county there operating in the same space and really have taken it to the next level. Another example here of the city and county kind of working together, coordinated case management for youth, specifically at risk of gang involvement. So there is a team of professionals here you see from multiple multiple professions, be it education, social services, working together really to encourage and drive policy and to work with these kind of teenagers. I think we'll see through our cure violence model that the city and county are going to work together. We'll see some things that are similar to this working in this space, but definitely an area where city and county of Durham have very much worked together. And the DEAR program, I got an error message. Can you all see this? Is the PowerPoint? Okay. So we've got the Durham Expunction and Restoration Program, which is DEAR. There used to be, I think, a nice graphic down here that PDF decided not to show you, but this is very similar to the DRIVE program that we have here. And I will tell you, ours is actually modeled after Durham City and Durham County's program. And they both the city and the county provide funding to it, but it's a driver's license restoration program. Durham was really on the cutting edge, I think maybe 6 years ago doing this, and we partially modeled our program after theirs. I will talk, so we showed the kind of the community agency funding that Winston-Salem and Forsyth County do. For the city of Durham, this is it in terms of where they provide community agency funding directly out of the city's budget. There are a couple of places, again, where departments may be funding something. You may have some youth intervention programming done in the police department where they have police directly manages the contract. I will tell you, I talked with the Durham city budget director many years ago. They were struggling to balance their budget during the Great Recession in the 07, 08, 09 areas. And one of the places that they eliminated funding was to community agencies, and they never restored it at the level that they did before. So they do have a couple of specific programs that they fund here, but not nearly as many direct contracts being managed as, say, the city of Winston-Salem has compared to Durham City. The reason you don't see one for Durham County, they don't have a list like this. Any of the nonprofits that they are providing funding to are done directly as service agreements through the individual departments providing those services in public health, behavioral health services, social services, those types of areas. So it's a little more difficult here to find where they might be collaborating. And I think in conversations, Janice would have told you that the city doesn't have a lot that they're doing. The county doesn't have any on a list that's just generally administered, but have them in the departments, and probably wasn't a lot of collaboration about duplication or funding the same services. When we talk about Raleigh and Wake County, so Raleigh's got a substance abuse advisory commission. Kind of interesting to see, again, a city operating in the space of being a primary provider, or even having these advisory commissions in substance abuse, which is historically and typically a county function. So I think the very interesting thing there is just that Raleigh is directly operating in that space. Again, when we saw affordable housing, we saw Wake County directly operating in the affordable housing space, which the city of Raleigh had historically done. So you do see in Wake County and Raleigh, they're really starting to blend across those lines of who provides the services and how they provide them. And again, I apologize. PDF is not producing our graphics here. The City of Raleigh Acorns program is similar to the BEAR program. All you would see in this graphic is it just has an acorn and it says the word acorns with what it stands for. But this is a small unit. This one directly embedded to the City of Raleigh's police department, but where they're doing outreach and referral services as part of a co-response model, and also doing kind of those wraparound service referrals on the back end from the office. I think they've got a total of 4 or 5 folks that are doing this. I don't remember the exact number, but again, this is kind of that co-response or mental health response unit from a law enforcement perspective. If we don't need a law enforcement unit, can we provide those services or referrals without sending someone with a badge and a gun? So Raleigh has this program. I'm going to go through a couple here, and I'm just going to bang through these. Raleigh is on the other side of the equation from Durham in that they provide, oh my gosh, they're not there. The graphics have fallen out. Let me end this screen share and see if I can reopen this document, because I really want to show you this. Raleigh provides a lot of direct funding to community agencies operating in those spaces. And I apologize for the technical issues here. Give me just 1 second and I'll see if I can reopen this presentation. Okay, screen share. There is the lovely acorns graphic that you missed out on. Sorry about that. And so from a human services area, Raleigh has these kind of in their budget document. And then we get to human service agency grants. And so Janice I told her literally just copy and paste in, and you see all of the areas that Raleigh, think about Meals on Wheels. That is typically an area that the county would be involved in. Medical services. And again, some of these may have overlap in terms of if they're CDBG funded, but Raleigh, more so than Durham, a funder in some of this area. I think we've got their arts programs too. We showed you kind of what the city is doing for arts. Raleigh is on a whole different level with the amount of funding that they give to the arts, but they have their public art commission actually dole all of that money out. Just a screenshot to show you that they're just operating in that space. But interesting to see, Raleigh has a lot more direct service contracts than Durham does, just a difference in where they're operating in those spaces. So the crux of that was to say each city and county is funding things a little differently, whether they're doing kind of managed central contracts with 501c3s, or they're letting departments do it, whether they're not getting into the same space as the county or they're overlapping. There's no best practice to be gleaned here in the research that we've looked at. And I think a lot of the questions just are around, where is the city currently operating in an area that the county is providing a similar service with a similar outcome? How do we move on that continuum from communications through collaborations? And if we want to provide a service jointly, having those conversations about, are we really supporting the same outcomes? And if so, we should probably define what those outcomes are. And then that second piece is, and this is really kind of the city council directing this, where are we moving as a city into places we've never been before, and providing funding for things on the horizon where we should have those discussions on the front end, talking with the county, rather than providing funding for it, operating in the space, and then going, oh, hey, county, aren't you doing this too? Let's talk about what we're doing together. And so there may be some of these areas, again, in mental health and substance abuse, where the county wants, the city council wants to get more involved and provide more funding. Sometimes those things come up organically, and I don't know that I have a good handle on what those next 2 or 3 issues are, other than the ones that are already presenting themselves. So again, I think those slides and a lot of the research that Janice did and talking with people, what came out of it was there's a lot of talking about working together. There's a good amount of communicating so that staff probably knows what staff is doing, but there's not a lot of joint service provision other than that. You saw that Durham model where you literally have a county employee in a city car. There's not as much of that going on where we're jointly providing the service and jointly funding the service. I do want to, as the budget director, make a note real quick. Denise said there's a lot of money out there and we've got all the money we need. A lot of that money is county related because the county is statutorily charged with providing that service. The county gets that money, not the city. From the opioid services perspective, that those settlements, the county's amount of funding for opioid settlement is multitudes higher than ours. I would say 3 or 4 times what we're getting, and it may be even more than that. I believe our annual distribution is going to be in the $150,000 a year range. And where Denise talked about where we might overlap, we're actually looking at using that money to help fund the BEAR team. A lot of the response that they're doing is going to be to issues associated with substance abuse response. And so we will probably use that funding to help pay for the BEAR unit that's going to be responding to those types of calls.
Yeah, would potentially cooperative efforts like we saw with the Durham response team be a little bit of a funding workaround potentially? And not to say that, you know, the city is entitled to more of those funds than other parts of the county, but if the demand really were focused in one place versus others, would a cooperative program between MIH and BEAR be kind of a way to join forces, not just physically, but also financially?
I think so, yes. And Janice again did that research, and my best understanding of it was the county knew they were operating in this space, and so they took their current, so they didn't add EMTs to do this program. They took their current structure and said, these people are already responding to these calls, but it seems like we're sending a cop car and an ambulance in Durham City. You got this other program. Let's take somebody kind of out of one piece of apparatus, put them together, let them respond together and really work together. And so that's an area where you can say it's joint funded, but it didn't cost anymore. There was an efficient way to get those people to work together to better provide that service to the folks that are in need. So absolutely. I think those are the wins that we're always looking for is where can we do that? And it doesn't require additional funding to get there. The opposite side of that is on the Durham City side and on the city of Winston-Salem side, it did cost us more. Though the response unit from the city is in addition to the regular city budget. So the BEAR team is an $800,000 plus unit that was in addition. They're technically housed in the fire department here. But that's in addition to our regular operating budget. So the county was able to provide a service without increasing their budget, but the city did in order to get into that space to operate there. I know it's a lot of information that we threw at you, but I'm more than happy to kind of answer any questions or look for places where you'd like us to dig a little deeper too.
So Scott, this is more of a idea than a question, but have you guys, has the city and county considered doing, with respect to the community agencies, joint review panels to review proposals? Because I do grant reviews all the time for different federal agencies, and it's pretty common for there to be, scientific review panels that cover an area, but then, they go out to like 4 or 5 different, say, institutes of health that are contributing the money. So like, there's a centralized review panel, And then the different agencies decide how much money they want to contribute and which of the particular things we recommend they want to pick up is the word it's called. That would kind of avoid a little bit of, of overlap between the proposals, frankly, and maybe more transparency in terms of what the city's funding versus what the county's funding.
So Fred, let me address what might be a recommendation from CBAC and then reverse into almost answering that question for you. If that is something that you as a group think is a good idea, it would absolutely be within the scope of your work plan this year to suggest some type of joint scoring committee, allocation recommendation committee. What I would tell you is currently the city and county have separate processes, both administratively and politically, in terms of what's recommended and funded. When ARPA came along, there were discussions about should all of the applications go through one central, I mean, even just to make it easier for the community, should you just have one application site? One application, even if you've got different agencies doing it. The next realistic question was, should we use the same criteria to score them? And I will tell you, Fred, from where we're at, the city and the county did not agree on the criteria that would be used to evaluate those. And so it was somewhat of a non-starter. Maybe the first thing you do is recommend kind of that communications and somewhere in the collaborative, hey, at least know all of the places where you're funding the same agencies. And then if it makes sense, maybe a phase 2 or a second step is there an ability to provide some type of joint recommendation and really process efficiency so that community agencies don't have to submit a county application and a city application through 2 separate portals that ask for 90% of the same information. That happened in ARPA, and we talked about this last year, but there were quite a few agencies who were mildly confused over who they were asking money from. And several folks who submitted an application to the county who called me and said, hey, where am I at in the process? And I told them, you're not in the process. We don't have anything from you. And so some of it is the customer service kind of component of it. And then some of it is that service delivery or funding mechanism on the back end. But it would be well within your scope to say you should look into this. Absolutely.
I mean, I think from both an efficiency and sort of transparency issue would be a great idea myself, but I don't know what the other people think.
Anybody else can chime in there. I will tell you, we keep a little running list of potential recommendations. And so either at the next meeting or the following one, we'll come back with, hey, we've heard these 6 or 8 things and have a more robust discussion on each one of those and whether it's something as a group you might want to recommend.
Yeah, I have
it's an
to
interesting
agree
idea.
with Fred because I think in one of the meetings we had last year, I forgot who was presenting, but it appeared that the same company or the same potential grantee had applied to both pools.
Oh, yes.
In county. So to avoid that, so more applicants can be maybe selected or given a chance, we're not funding the same applicant from the city fund and from the county fund. And yet instead there's those that met that second criteria that the commissioners came up with. And they received less funds because there was 2 or 3 agencies that received a lot of money. And there were some complaints at one of the public hearings about that. So I think that would kind of narrow down some of the complaint. I know we can't fund every application, and it also give both agency, the city and the county, a good look at where the funds are. I think if we do a joint application pool, it also will allow both city and county to have better oversight over the grantee and to make sure the funds are being used the way they propose, and also some intervention before something goes awry and the grantee cannot fulfill the commitment to the proposal. So,
Yeah,
Sheila, did you?
I was going to try to, and if the city and county decide to fund both something jointly, at least they know they're deciding to fund something jointly. It's not a matter of, oh, this person sent in the proposal to both and, oh, it got selected for both, even though it might cover the same exact thing. It's a conscious decision by both of them together to decide to fund it together.
Yeah. A great example of what an agency had to do with this is Old Salem. When we opened our concurrent ARPA processes, Old Salem actually had to call and work through this, and they asked for only capital funding from the county and only operating funding from the city to ensure that they would not duplicate their request through ARPA in any way. And they could tell us, no, we are specifically asking this for you and this from you. But yeah, if there was one process, that would be a little easier for them. I will note here, I'll back up to the 30 or 50,000 foot level and say that there are political processes involved here as well. So even if you had a joint committee to do this, that is most likely a joint scoring or recommendation committee. Devolving the authority for actually funding those away from the county board or city council would be very difficult, most likely.
Not advocating that, like, at
Okay.
the NIH, for example, we score, we evaluate, we do not make funding decisions. That's
Gotcha.
at 16 different NIH councils. They decide the funding. Yes, that's not our authority.
Very good.
We score, we can recommend. Actually, technically under NIH bylaws, anything we score in the bottom 50% cannot be considered, but that's their own conscious decision. In the top 50%, that's out of our hands. We recommend and score only.
Do what you feel. Very good. Other questions, comments, concerns in this area? And again, I know we threw a lot of tables out there, and the intent wasn't to talk about individual agencies, but more just those types of areas, whether it be, mental health, substance abuse, elderly services, youth programming, the areas where there's just overlap between us. Any questions that we can jot down and potentially reach out to city or county departments and answer for you?
So something that I didn't quite get is Barbara Price, was that her name? Price.
Denise.
Denise. She talked extensively about the services the county were providing.
Mhm.
I couldn't tell if the Bear team overlapped with that or not. It wasn't sure to me. I don't think they do, but it wasn't entirely clear. And also the other thing is, the Bear team, if I understand right, they respond to the low risk calls. Would they take people to that place you mentioned, which I'm looking for?
Highland Avenue. Yes.
Thank you. Yes.
Yeah. So the Bear team would be able to do transport services, and that hits on what Tony had asked about earlier. And so the Bear team started as an idea with the city of Durham working with RTI, and they got a grant to just think about non-police interventions to calls. It became a little more realistic. We started looking at our data and we asked the question, what types of calls don't need a law enforcement officer on the scene? And so the Bear program is really on the city side as much about how do we keep a law enforcement officer away from the scene and responding to a thing a law enforcement officer should, as it is effectively providing a mental health service. So part of our service provision there is really to allow our police officers to move on to the other priority one calls that they should be involved in. Where Denise is talking about that is you get a 911 call and it comes in and you've got somebody who's got a mental health problem, and that dispatch may involve a police officer and an EMT unit.
Mhm.
We may get to the point where, so the way that dispatch works, we don't send the police officer, we send the Bear team.
Okay.
But because it's got some kind of physical health component, you're also getting an EMT as well. And so that intersection, and again, this is kind of getting out of my expertise, but that intersection of where do you get the Bear team with the clinician and the EMT unit with the trained up EMT, if they're going to show up at the same place, do you not need both of them? Or like Durham has done, can you put them together and just know, yeah, we're going to send that full response with all three of these types of people?
So I guess, so it sounds like this idea of separating out. So police it's violent essentially.
Sure.
Bear when it's mental health and drug, and EMT where actually physical, which could include drug. It sounds like the Bear versus police is sort of established now. but the bear and EMT is still a work in progress.
I would think very much so.
But I do like this whole thing that you guys are doing. I mean, that's why I'm asking about it. I think it's a good idea.
I would venture a guess that Denise's 10:30 with our Bear team director was to have some of these very conversations about where are we overlapping in service and how do we help each other? How do we get out of each other's way when we don't need to be there?
Because that'd be great if there's a streamline with the dispatch had a streamlined way of being like, okay, this needs bear and EMT, or this needs, I think that'd be a phenomenal thing. Last question along this line is, she mentioned there is a peer support specialist. I think the name is Jose at the Central Library. And he works mostly with the homeless, it sounds like. I would imagine that's a lot of people who need the bear people. Does he have any ability to dispatch them or work with them?
I have no idea.
I figured that would be your answer, but can you put that down as a question?
Absolutely. That who can call for the bear team will be a very interesting piece. I don't know for obviously when a 911 call comes in, that's an emergency call, but from a non-emergency perspective, how they can be. That's something we could get Kristen to come and talk about that maybe next time or the time after that and give you guys a better example. Like I said, I don't believe she was available for us today. It would have been good to have her, but weren't able to get that scheduled. So.
Right, like in the same way that you might not want to tie up ambulance services with a non-direct crisis to, the Highland Avenue Center, is there a way to kind of coordinate that kind of transportation and immediate response capacity?
Yeah.
And yeah, Jose would be a great kind of point person for that, but I'm guessing that need probably exists elsewhere as well.
As this is thinking that's a person dedicated to that position already, it would make a great deal of sense if he had some ability to coordinate people and get them out. Yeah. But I'm eating my breakfast, so I'm turning off my video often.
Or either just put like the Durham unit has, putting all three together in a unit. So from behavior health, the EMT person and police service, just make that a unit within itself. So they specialize in these particular type calls and maybe rotate the different individuals out, but there will always be 3-person or 3-team that would go out to mental health. But one of the things I have a question about, Scott, is you said something about outcomes between both divisions, city and county, about how to get them to collaborate more. And I think that between the county and the city, finding out what are their desired outcomes, what are their top priorities, and where are they willing to be flexible before we can make some recommendations to on that particular topic. Because if the county outcomes is ABC and the city is saying we still trying to figure it out, we want to see it, there's going to be a clash.
Yes, there will be.
So I think if we could come up, get some perspective on what type of outcomes is the council looking for? What are their expectations? And again, where are they willing to be flexible in what area?
Yes, I will share this. It was probably about 1.5 years ago. Patrice and I did a joint presentation to the city council on our community agencies funding process that we have here in the city. And one of the questions that we asked the city council was how intentional they wanted to be with prescribing outcomes on the front end. So basically the way our community agency process works, if you're a 501c3, you can ask for money. You can basically say, this is what I'd like to do in the community. And so we went to the city council, and one of the options was you could be very prescriptive on the outcome and basically have people almost bid as a service contract on that outcome. What that does is it eliminates a lot of people from being able to request funding. And in some cases, it puts us in a space where we don't have the right expertise to fully manage some of those outcomes. I mean, that's one of the things to talk about, Haysetta, is if we're looking for mental health outcomes and we're looking for public health outcomes, is the city really even the agency to manage that entity? Or would we be better off letting the
pushing it
county
over.
manage it and
Yeah.
simply being a funding provider in that? And so that's part of that whole conversation too.
So did maybe I misunderstood something. So other than it being an issue within the city, why not do that? Because it seems like the county health department and behavioral health have more of the expertise. So now we have to hire people taken from their pool of employee or potential employees. And could we focus on something else, like you said, just being the funding source? And that will not see it, because in one sense, as I was listening, it was like, are we competing against each other still, even though we're using different terminology, saying we're going to collaborate, but in one essence, we're still competing because we haven't come to a conclusion on what we're willing to, collaboration is just talking. To me, we're talking. The action part, the execution plan after the collaboration, that's why I don't see us. I mean, and then we're spending, I don't know how many hundreds of thousands of dollars on this bear unit. Is, I don't know, maybe I'm looking at it wrong.
Again, there are political processes at play, and there were a lot of folks who came to the city from the community and said the city needs to do this, and the rationale for it was twofold. Part of it was, yes, we'll provide a mental health service through this, but the other part was that we don't want somebody with a gun and a badge at that place. And so the intersection on the city side was, we created a unit where I would dare to say this, almost the secondary component is providing the mental health service, where the primary reason for it was to not provide the wrong response to it. So it's interesting. So the county would be doing this because they're charged with doing mental health services, and the city is doing it not because we're charged with mental health services, but because we want to avoid incorrectly escalating a situation that does not need a badge and a gun at it. So in that space, we've almost gotten at the same thing, but from two different angles. And again, I'm the budget director, so I'm kind of giving you the research purview and the folks that we've talked with that have done this in other places. But I'm sure if Kristen were here, or even if Denise were still on this call, she would give you a different perception or angle of how that works too. So don't take mine as the gospel. That's just kind of what I've seen.
Okay.
I will note that we do have an 11 o'clock meeting with the mayor, so we'll go another 5 or 7 minutes here, and then we may have to cut this off just before the 11 o'clock hour if the questions are continuing. But look like Tony and Fred, you both may have had something to say. Okay.
Not really. I like what you guys are doing, especially with the Bear team, and it was good to hear the overview from the county. I made my suggestions about joint reviewing and about streamlining maybe getting a process where the dispatch can do any of those 3 units at once easily, and the idea of maybe letting that community liaison guy or peer support guy, whatever he's called at the library, be able to dispatch the Bear unit as team as well, just because he's already there as a point of contact with probably the population that needs it the most, or one of them.
Gotcha.
Those are the only 3 points I really wanted, and otherwise I'm good.
All right. Anything else that we want to discuss this morning? If not, I would say thank you very much. I believe Sheila had to leave, but I want to say thank you for everybody's time this morning. We do have a couple of other things on the agenda actually in the next 2 or 3 minutes here. One was election of chair and vice chair, which we haven't done. If there's anybody who would like to serve as the chair or vice chair, we could take recommendations and nominations and do a quick vote here. If we wanted to, Tony, Fred, James Cena, he said, I think you've done 1 or 2 of these roles in the past.
I nominate Tony and Fred.
Sure.
Fred's back. So
Yay! Yay.
Formal nomination, we would have a chair and a vice chair. Tony or Fred, informally, does either one of you want to be the chair or the vice chair?
I'll take whatever one Tony doesn't want.
All right, Tony, you're on the spot there.
I nominate Fred for chair.
Sure, fine with me.
Okay, so we will do just a quick vote on that. I'll do it in two separate motions here just really quickly, but we've got something on the floor for Fred to be chair. We'll take he said it, has said it, and we'll call Tony as a second. Just say aye if you're okay with Fred being chair.
Aye.
All right. That passes unanimously, and then we'll do the opposite and say Tony for vice chair. Again, motion by Haysetta, and we'll say that Fred seconded that because he said whatever Tony wanted. And we'll take a vote there. Just a quick aye if we're good with Tony being the vice chair.
Aye.
Sure.
All right. Well, we'll call that an official vote of the CBAC. Appreciate that. The only other thing that actually wasn't on the agenda was approval of the minutes. So if the group had a chance to read the minutes that Tanya sent out and wanted to approve those or make edits to them, we could edit and approve those minutes from the prior meeting.
I might make a motion for approval.
Okay. I'll take a second from
Second.
there we go. And does anybody have any conversation or edits to that? If not, we'll just take a vote. Everybody give me a thumbs up or an aye. All right, we'll call those minutes approved from the prior meeting. Thank you very much. Next meeting is scheduled March 15th, 9 a.m. We will get the materials out for that as we do for all of the meetings. Thank you again for your time, and feel free to reach out to us if you need anything else between now and then.
Okay. Bye-bye.
All right.
Thank you, everyone.
Thank you.
Bye.